Good evening everyone. Welcome to the second webinar in Microscope series, which we are going to have with one of the most renowned surgeons of the country and one of the greatest teacher of all time. He is no other than Professor Chintamani. A very good evening to you, sir. In this webinar, we are going to take up clinical cases which were posted in the group, some of the ward round cases and many other cases which for which we'll have a discussion on the diagnosis and approach. So we now begin with the first case. So the first case, the image of which was posted in the group as well. She's a 35 years lady who was operated for recurrent phylloids in which skin sparing mastectomy was done with latissimus dorsi flap 4 years back. She received all the cycles of radiotherapy and the histopathology report was suggestive of all the margins which were free of tumor. Now presently she came up with a fungating mass in the right breast which was operated last time, and she also had another lump of around 4 into 3 centimeters which was hard in consistency, fixed to the underlying structures, most likely posterior chest wall and little closer to the donor site. Now I would like to ask sir that how would we approach this patient?
Good evening viewers, good evening Sukriti. Thank you for having this webinar yet again, and I am so happy that a lot of you gave us a feedback that you would like to have more of these webinars. The case is posted and incidentally the case has also been operated. Now I'll tell you about this case's background. Sukriti has given you a background. So she actually received the complete treatment 4 years ago. So it was a phylloids, malignant phylloids that is, who had received a complete therapy. All modalities were provided to the patient, but in spite of that she has come back with a recurrence. Now first of all, why recurrence? You see, the trouble is with phylloids, especially the malignant phylloids, when we operated it was a recurrent phylloids at that time, and the first surgery was for benign phylloids. So even the first surgery did not have positive margins, it was done somewhere outside. So we took it up as a sarcoma and we did a complete, actually a mastectomy. That's the maximum you can do. We did skin sparing because in phylloids especially, the skin is rarely involved, and it's one good opportunity to do, this being a young lady and phylloids being a tumor that doesn't involve skin, it makes a lot of sense to do skin sparing mastectomy. We are obviously not going to address axilla, so it's not an MRM. So a mastectomy followed by latissimus dorsi flap reconstruction, that was done. We are happy with the result cosmetically as well as oncologically because patient did very well for initial 1 year, but was again like the same old tragedy of our patients and our system, fatalistic attitude. She thought she's cured and she actually had a baby after that and never came for a follow-up. Now this started as a small lump again. Now there are two questions here. Once the reconstruction has been done, is it easy for the patient to identify any recurrence? It is difficult even for a clinician, mind you. That's why they need to be followed up with the breast surgeon regularly. Why? Because there is no breast tissue now. Where is the recurrence? We'll discuss it. Now there is no breast tissue, it's just the latissimus dorsi muscle. That's what we have done, and it doesn't feel like the contralateral breast. For a patient to find a difference even while bathing, to detect that there is a malignancy. So I don't blame her, although if she had come, maybe we would have got to detect it earlier. This is what we feel. She detected the lump about a year ago, so I think that was the time. If she had come, it was possible, and then it progressed very rapidly. It is fungated. If you really look at the image, it is a big fungating tumor, and you would suspect that it is fixed to the chest wall, which it was not clinically, and patient was obviously to be worked up and to be treated. Now we had exhausted radiation. The options we were left for to do surgery again, and maybe that non-effective kind of chemotherapy which doesn't work very well in these patients. So we went for working up. So what do you do to work up? Our aim is to find out if there is any metastatic disease. But unless you exclude metastasis, you cannot go for a definitive resection locally, because that can amount to some morbidity. I'm only discussing the fungating mass right now. So what did we do? We did CT thorax, we did CT abdomen, we did a bone scan, and of course CT thorax included the upper abdomen, so we excluded metastasis to the lungs, to the liver, to the brain, to the bones. She was not symptomatic for any metastasis, and touch wood, she had no metastasis. Any role of PET here? Probably this is one place where PET would be very useful if there is avid activity, but we don't know, and we did not do PET because we don't, as a policy in my unit, we don't follow it because it does lead to problems. We do pick up nodes here and there, and then we don't know what to do, especially in the mediastinum or in the pulmonary area. We can pick up a node and patient may lose the only opportunity of a curative treatment. So this was about the imaging that we do. Do we need to do a core biopsy to confirm the diagnosis again? Well, it's a fungating mass. You can take an edge biopsy from anywhere, exclude a necrotic area. But you can have a good question here. We did skin sparing mastectomy. Now there is no breast tissue left. So how is this tumor coming out? Well, that clearly shows the tumor is not out of the breast. There is something else which has also happened here. There is a hard lump on the chest wall, close to the donor site, as Sukriti was saying. Now, it's a chest wall lump. The donor site, hopefully you'll see in the incision for the Let's dorsi flap, I usually use the bra incision, so it's below that. But the activity does happen there. We have removed the Let's dorsi from that area. Now, interestingly, this was not a mobile lump. So we were a little concerned as to what is it? Is it a part of the same disease or a new disease? Now there is a question of post-radiation sarcomas that happen in these patients. So with all this and everything else done, CT thorax made a suspicion of this lump or this tumor being arising from the rib, and 12th rib was and 11th rib doubtfully were seen to be involved, and intercostal muscles seemed to be involved. So chest wall lump therefore. So ribs and intercostal muscles. There was no effusion. So there was no suspicion that it has gone into the pleura. And because there was no effusion, we thought there is not even a metastatic disease there. Now with this background, we didn't have a choice but to go in for surgery. I would suggest that you read one of my articles long back. I published it. Is an aggressive approach justified in the management of an aggressive tumor? The answer is yes, because you cannot take it as a tumor which is going to wait for too long. This would infiltrate everywhere, and then probably the only hope of surgery would also go. So this patient was taken up for, so the question, your question was, what do you do now?
Yes, sir.
So work up first of all for metastatic disease, local disease extent, taking a very good consent from the patient. Now we have lost the LD because we have already used Let's dorsi. The only option I had was to go for tram flap, which I thought I'll do.
So I have a question here. That is there any role of doing preoperatively biopsy from another lump which he has in the posterior?
Oh, that's a brilliant question. Actually, we did it. We discussed this case in the tumor board, and everyone believed that it's the same disease, but I went in for a core biopsy, and you're right, absolutely right, because both of them would qualify as new primaries, and they don't necessarily need to be the same. The core biopsy, in fact, I can't help but repeat again, it's a very good question. If the core biopsy was Timbuktu, my answer is still the same. The question is valid because it's a second primary and it is a different tumor. I think it's got something to do with the radiation, as we saw during surgery. But yes, we did a biopsy and it showed it to be a sarcoma. They did not qualify. Remember, sarcomas form 1% of all the tumors, and there are 100 subtypes.
Yes, sir.
So this would be, it will be impossible to know on core biopsy
Right.
as to whether it's different or not. But yes, you have to treat it like a sarcoma based on core biopsy. So we did the core biopsy, that's correct. And then we have the GTNM classification. I'll treat both of them as new primaries because they're beyond the time of recurrence. They happened after 6 months of complete treatment. Patient has received the therapy completely. So new primaries, both of them.
Yes, sir.
Now we took it up for surgery and we took a consent for tram flap. And my plan was to put a tram flap, but my concern was again the other tumor. What would the patient need more? Because should I lose the tram also? But you don't have a choice. So we left an option of tram flap with us and a Leica flap, which I do. We have published our data long back. It is not Doppler detected, but we can do now Doppler detected perforators. Leica flap is a lateral intercostal artery perforator flap, which is based on lateral intercostal arteries. If you go, if you have watched modified radical mastectomy, including my own videos that I've shown and the model that we shared, the lateral perforators also come from the intercostal vessels. The anterior perforators from intercostal vessels which supply the breast, skin and the flap up, and the lateral. Medial perforators are coming from the internal memory also, which are used for the deltopectoral flap. Yes. So this is a laterally based perforator flap which we try randomly. You know, we have tried many cases and it works quite well. The only advantage of that flap is it's less morbid, quickly done. Patient doesn't lose blood, because in the surgery itself patient may lose blood.
Yes,
And sarcomas are bloody tumors, so we have no choice but to be prepared for it.
right, sir.
But should I tell you what we did, or?
Yes, sir. What was intraoperatively done in this case?
We took up the patient for
So,
sarcoma surgery. So won't call it mastectomy, it will be a wrong answer. We did a sarcoma surgery with a wide local excision going one plane deep. So actually it will amount to getting the pectoralis major out. And the muscle was not directly infiltrated. It was at a couple of places where there was a doubt. Serratus anterior, it is actually kind of a big looking tumor with a narrower base. So it was fixed to, it was arising from the previous point where Letzmann's dorsi and pec major were joined. So we went right up to the attachment of Letzmann's dorsi, that is to the humerus,
yes, sir.
and we found that pedicle, the pedicle was there, and we did find that pedicle was intact. We transected from there, we transected the pectoralis major, and the whole thing was taken off as one complete resection with a negative margin. And we did do a cavity shave from the Letzmann's dorsi, from the medial side, from the serratus anterior, and from the rib by periosteum elevator. The second part,
Yes, sir. What was done for the second tumor in the posterior chest wall?
we had then to shift the patient, turn the patient laterally, and we went for a sarcoma surgery of the second tumor. And that meant removing some bit of skin where the core biopsy scar was present. And I'm sure it will be, if there is a video which you can share, you will probably be able to show. We went one plane deep and we just hit the rib. We resected the rib along with it. There was a pleural breach at one place, which was because we wanted to take a shave. So we repaired the pleura, and it is again an R0 resection. But that could be closed by bringing the other ribs together. And there was no recurrence there from the Letzmann's dorsi flap. So this looked like arising from the chest wall, looked like a new one, completely different
Yes, sir.
from the primary. It had a lot of necrotic tissue in the center. We saw that, and when we opened it, and we took out the rib, repaired it. That part was done, and then we reconstructed using a Leica flap. That's what we did in this case.
So that was a very taxing surgery it must have been. And what would we do in the post-operative period for the management of
Brilliant question, because no radiation now. So we will pray. In the post-operative period, we will pray, because we cannot put the patient on any therapy in terms of radiation right now. But we have an option of chemotherapy. We can put the patient on some bit of chemotherapy, but I don't know what is the other tumor. We just did it last week. So hopefully we'll, by the time we get the result, we'll discuss it again in the tumor board and also in my own unit board that we do. We have a discussion every Thursday and we discuss all these cases. Everybody has the freedom to express. And we discuss it in the CPC with the pathologist. and then we take a decision. So I would not answer that randomly, but as far as I understand, we'll just pray that she doesn't get another one. This is all that we could do at this point of time. Can we give radiation second time? I had a discussion with the radiation oncologist privately. In the tumor board, he might just stick to some guidelines and keep bothering me. It is possible to give it, but that's called palliative radiation. But this is chest wall, mind you.
Yes.
And pulmonary fibrosis is a major morbidity. So if the margins are clear, let's answer that question this way. If our resection is R0, then we have options of putting the patient on chemotherapy. If the margin is positive, then we had it anyway, because the margin is not likely to be positive because the frozen didn't come positive. So we are hoping that we will be able to provide treatment based on what is the result of the second sarcoma, second tumor. First one we have already, we know what it is.
Yes, sir.
So interestingly, why this case is interesting is we have seen post-radiation sarcomas happening, say in the upper limb. It happens following elephantiasis, we know that. And that is lymphangiosarcoma. Similarly, it is similar. They are very aggressive tumors. But fortunately for us, she has no metastatic disease, so which is somewhere in the middle. So we'll hopefully keep her in a good follow-up and provide the treatment based on the histopathology of the first tumor, the second primary.
Yes. Thank you, sir. There were some questions which were posted by the students in our microscope group, and I would like to request, sir, to discuss these questions which were posted by the students. I would like to first read out all the questions for the convenience of all. The first question which was posted was the imaging modalities which are available and in the breast cancer for the diagnosis of the disease. The second question was about, which is a regular question in the exams, the role of coneal biopsy and why do we need it for planning of the therapy before surgery. And the third question was about the locally advanced breast cancer. We read about the various definitions for locally advanced breast cancer. So how do we actually and appropriately define LABC, which we can also give the same definition in the examination. The fourth question was about the inflammatory breast cancer, which strangely forms a part of locally advanced breast cancer. And since you have mentioned earlier that it's a very different cancer, so if you could elaborate on the management and the diagnosis of inflammatory breast cancer. Then the fifth question was, what is triple negative breast cancer and how does it really matter if to know about the status, the ER/PR and HER2/neu status of the disease. The sixth question was about, like last time you discussed about the role of chemotherapy, and this time the students want to know the role of radiotherapy and hormone therapy in the management of breast cancer. The seventh question was about a video that you had posted on the YouTube, which was on round block mastopexy, that was the donut mastopexy, and the students would like to know more about the breast conservation surgery, its indications and various contraindications and complications. So we'll take these questions one by one.
First of all, thank you very much for posting those questions. I think she's read out all of them in a flurry, so I'll try to recall. First one is about imaging modalities. I think we've discussed it, but we'll reinforce. Remember, there's no point in getting, the idea of these webinars is to provide you with answers that you can very comfortably offer in the exam. And you don't have to defend a lot if those answers are given. So, imaging modalities are primarily three. Mammography, most sensitive. Ultrasound for denser breasts, younger patients, pregnant ladies. And also post-surgery, post-therapy, because there's a lot of scarring in the breast. So it is a mammography may distort the architecture, you're right. Now MRI is something that you would like to know about. That's why probably the question, because the way it was posted, it looks like that. Now MRI is called a problem solving tool, which means When ultrasound and mammography are equivocal, then MRI can be done. MRI has one problem. It's a very sensitive tool, but not very specific. Now, anything that is very sensitive, it's like having a matchstick person who just jumps, gives an opinion, or scares you, or is a scarecrow. MRI basically picks up artifacts and picks up almost anything. It lights up everything. So what does that do? It reduces the incidence of or the numbers of breast conservations that can be done. So MRI is not very popular with people who like to offer breast conservation surgery, although it has very specific indications. There are very famous radiologists, especially Laszlo Tabar conducts a course on breast imaging, which is outstanding course. I happened to attend it 3 times long back. It is there that you realize MRI, if rightly read, can be brilliant. I mean, he could almost give a histological diagnosis based on MRI. He was so good. He's so good at it. Same Tabar, who was the milk line of Tabar. That's the one. And that's where cancers happen very frequently. Anyway, so MRI, your answer in the exam, you will not do MRI as a routine. You will do MRI if there is an equivocal diagnosis, and rarely if you want to rule out multicentricity in a breast conservation surgery. But like I said, mammography, a well done mammography is usually enough. Now I often say, and that is what you probably were referring to, ultrasound is a poor man's MRI and MRI is a rich man's ultrasound, because it detects the soft tissues very well. When is the breast dense? Young girls, young women, or pregnant ladies. So that's where mammography doesn't have a very good sensitivity, doesn't pick up very well. And also in pregnancy, radiations cannot be used, although they can be used with the pregnancy shield, but then that's not why you should do. Why should you do it? But mammography, your answer in the exam is the gold standard. Now, most centers today do sonomammogram. So they do ultrasound in all cases where they're doing mammography, because now breast ultrasound, the breast radiologists are coming up and they are very good at their job. They are able to give a very specific diagnosis, and they are able to pick it up much better than a general radiologist. Ideally, like we do our own ultrasounds for the breast on the table also we do that. That is usually what we should learn. Remember, I mentioned last time also, today the TNM staging that has come in AJCC 8th edition has been defined, the one that you detect clinically as well as based on ultrasound. Ultrasound is necessary because without ultrasound you cannot say nodes are negative.
Yes, sir.
You need to, on ultrasound, say that.
An extension of the clinical.
It is an extension of the clinical examination, and it is the stethoscope of a surgeon, right? So ultrasound is ultrasound. Now very rarely you will hear this question, is there any role of, how do you assess recurrence in breast cancer? We have discussed a recurrent case.
Yes, sir.
Your answer in the exam again, clinical examination is the best. You will hear from various people, MRI, ultrasound. That's not correct. The most important examination is good clinical examination, because most recurrences would happen in the subcutaneous plane now, because there is no breast tissue, we have removed everything, right? So it is actually, in this case, the tumor was in the Letzmann's dorsi flap. It was a sarcoma actually. It had nothing to do with the skin. Skin was still fine, but although it had fungated, we can't comment on it. That was one question. Then second one was on
the role of coronal biopsy.
the role of
its significance in planning the therapy before surgery.
Okay, so that means neoadjuvant chemotherapy.
Yes, sir.
Core biopsy is mandatory. It's the gold standard in the triple assessment. No longer FNACs. We need to do clinical examination, thorough history and clinical examination, followed by imaging and followed by core needle biopsy rather than FNAC. FNAC is not the basis of any treatment anymore. Now when you do core needle biopsy, you need to know the status of the ER, PR and HER2/neu. Why is core needle biopsy superior to FNAC? I am repeating for the benefit of all the students. We have first years in this group. There are lots of students who will be waiting to hear about all the basic things. So we should keep it focused only on the exam going students.
Yes.
So we would repeat questions and answers. Core biopsy versus FNAC. It's a debate which has been going on for a long time, but settled now. Gold standard is core needle biopsy. Can you treat a patient of breast cancer based on FNAC? The answer is you cannot. Why is core biopsy superior to FNAC? Number one, false negatives are higher with FNAC. Number two, core needle biopsy provides you with a histological diagnosis, grade, and most importantly, invasiveness. Because invasiveness cannot be detected on FNAC. So FNAC cannot differentiate between ductal carcinoma in situ and infiltrating ductal carcinoma. Sorry. The negative FNAC has no meaning. Positive can contribute, again has no meaning. Core needle biopsy can tell you about the grade of the tumor, as you rightly said. It tells you about the biomarker status. So actually it tells you about everything today. You can actually do the entire planning of therapy based on core needle biopsy. How? Suppose the patient is ER/PR negative and HER2/neu positive. That's not type A. ER/PR negative would be an ER/PR negative tumor. That's ER/PR positive, HER2/neu negative. So if you're looking at double negative tumor, that is, you would still feel that patient is going to respond well to chemotherapy. So there is a case for putting the patient on neoadjuvant chemotherapy. You are expecting a good PCR, which means pathological complete response. Similarly, if it is a triple negative breast cancer, invariably we will put the patient on neoadjuvant chemotherapy and get a good PCR and probably have a better outcome also. PCR stands for pathological complete response. If the patient is ER/PR positive strongly and HER2/neu negative, elderly, small tumor, patient may require very limited therapy, even if it is, if you're thinking about neoadjuvant, it's a larger tumor, but may not require neoadjuvant chemotherapy. You can go for upfront surgery. One very important advantage of neoadjuvant chemotherapy is the in vivo chemosensitivity that it will provide. So you can use that also as in vivo chemosensitivity test. So ER/PR negative, triple negative, something called as triple paradox. We've discussed it in the last webinar also, so we'll not repeat it. It is triple negative, so likely to do well with chemotherapy. So ER/PR, HER2/neu status lets you know about the therapy that you can offer in the neoadjuvant setting. If the patient is HER2/neu positive, we can offer trastuzumab even in a neoadjuvant setting. Is there any role of putting the patient on hormone therapy? Elderly patient, large tumor, locally advanced, ER/PR positive. We can put the patient on neoadjuvant hormone therapy also, which is given for 3 to 4 months, and you can look at the response. Sometimes the tumor may completely disappear. So it makes a difference. Therefore, I'm repeating, core needle biopsy is the gold standard in planning therapy subsequently, or in planning the optimum therapy even before surgery. With surgery, post surgery, of course, you have many things with you. And remember, negative FNAC doesn't mean anything. Core needle biopsy is the gold standard. Treating any patient of breast cancer without core needle biopsy is an offense. It should not be done. Now, don't cite limited facilities, because core needle biopsy is no longer a very expensive modality. It should be offered to every patient. It's the right of every patient to be offered the right treatment. You cannot offer less than optimum treatment. I hope that covers it.
Yes.
The third one was?
The definition for locally advanced breast cancer.
Yes. This was probably somebody asking because of the examination related answers. They need to answer because some books mention T3 and 0 also as locally advanced. Remember, today the definition of breast cancer is, the staging has changed completely. It's early breast cancer and advanced. And in advanced you have two groups, locally advanced and metastatic. That means distally advanced. So early breast cancer one side, which means it's early, means up to T2, up to N1, and of course M0.
Yes.
The moment it is M1, you go to the other extreme, metastatic. In between the two is locally advanced breast carcinoma. That's easier to remember. And like I teach in the scope course, T4 with any N and M0, or N2 with any T and M0, beyond this, NM0 is locally advanced breast carcinoma. Some people like to take T3N1M0, which they should. T3N1M0 should be locally advanced. Some people take T3N0, especially I think a couple of books. I won't mention them here. So there are many studies where they taken even T2, large T2s as locally advanced, which is basically because they are wanting to offer breast conservation to even those locally advanced. So the locally advanced tumors of the West are smaller than the locally advanced tumors of our part of the world. And there is also an entity called as LOBC, which is large operable breast cancer, where it is operable because you can get clear margins, but you can't offer breast conservation. If you have to offer breast conservation, they will also require neoadjuvant chemotherapy. So that's about locally advanced breast carcinoma. The definition is it's between early breast cancer and metastatic breast cancer. T4 with any N and M0. M0 is important, or N2 with any T and M0. N2 is fixed axillary nodes. N3 also would be locally advanced, which is supraclavicular ipsilateral nodes. T4 means fixated to chest wall or the skin or to both. And there's one entity, inflammatory breast cancer. That's why there's a question, which is T4D.
Yes, sir.
T4A, T4B. T4A is fixated to chest wall, which means ribs, intercostal muscles, serratus anterior.
Yes, sir.
T4B means involvement of skin, which means satellite nodules, port orange. Besides this, T4 is combination of the two. Pectoralis major and other involvements are not. And satellite nodule is now taken as a normal island of normal skin. T4D is inflammatory breast carcinoma. And what is that question?
That since
Yeah.
it is considered to be a part of locally advanced breast cancer.
And I often say that it is different.
Yes.
That's right. Now, it is actually a different cancer, but they had no place to put it. They continue to put it in the locally advanced breast cancer. Inflammatory breast cancer was defined by Lee and Tenenbaum way back, and it is based on not just the examination findings. It is based on the history and examination both.
Yes, sir.
The short history of 3 months with rapid progression,
Yes, sir.
with rapid involvement of the skin, that is induration, erythema, peau d'orange, and fixed axillary nodes are happening early and very quickly. So history is important, and you generally cannot palpate a lump in the breast because there is induration, there is peau d'orange, and the skin is thickened
Yes.
because of the edema due to blockade. Why does peau d'orange happen? I think I've discussed it last time.
Blockage of the sublymphatic.
Blockade at the axilla where they all drain, and that leads to a reflux and stasis of the lymphatics, lymph in the lymphatics, which leads to, except for where the hair follicles are, the pouting, which leads to peau d'orange. So on examination, if more than, some people say 1/3 of the breast, some say 3/4 of the breast, I often say more than 3/4 of the breast involved, with no lump palpable, peau d'orange, fixed axillary nodes, happening over a period of 3 to 6 months, I would take it as inflammatory breast carcinoma unless proven otherwise. And most inflammatory breast carcinomas, I would say most means all, are triple negatives also. So they are very aggressive tumors that tend to do very badly. We don't do breast conservation in most of these. There is no sentinel node biopsy done in most of these because most of them have nodes involved. Most of them require neoadjuvant chemotherapy, and a lot of them would have metastasis early. So we need to treat them aggressively, and they are aggressive tumors. Your question is right. Should we put them in locally advanced breast carcinoma? Actually, there is no other way to put them anywhere else because they're neither metastatic nor early.
Right.
So therefore, they fall in the category of locally advanced breast carcinoma. This is the reason. How do we treat them? Active chemo based same. Management is the same as T4,
As locally advanced breast cancer.
as locally advanced breast carcinoma.
The next question was about triple negative breast cancer, and how does it matter if we know about the status of the patient? Triple negative.
I think we have covered it. Triple negative is a bad cancer because of the behavior, but not everything that is black is bad, as they say. It is,
Paradoxically does well with chemotherapy.
yes, good. And what is that called? When a triple negative does very well with the chemotherapy, it's a paradox. What is that called? What is triple paradox? So it's a triple paradox, which is that it does very well with chemotherapy, because chemotherapy acts on rapidly multiplying cells. We discussed it last time, so I won't cover it here. But again, for the benefit of those who have joined in later, rapidly multiplying cells do very well with chemotherapy. So triple negative breast cancers have a very good response to neoadjuvant chemotherapy. You get very good PCR rates. They tend to do very well, but they don't do well overall. But a section of patients where we get PCR, they do well. So therefore, it's necessary to put the patient on neoadjuvant chemotherapy, and this is where in vivo chemosensitivity will help us predict the outcome. So if you get PCR, which means on histology, the pathologist says there is no tumor there, we have done well.
Thank you, sir. The next question was about the role of chemotherapy, which was discussed earlier.
I think we've covered that.
I would like to know about the radiotherapy.
Yeah, because we have some case scenarios also to take, so I'll quickly take it. I think the second last question this is? Okay.
Yes, sir.
Well, we discussed chemotherapy last time, and partly I touched radiation also, although you're asking me again, but that's all right. Now, I would repeat the formula 345 for those who are joining in now. Make it simple, keep it simple. Any patient with any kind of breast surgery which has been breast conservation, radiation is mandatory. We discussed a case in the microscope group where the patient had a recurrence, the cervical nodes were positive. That case we could not take up today. If you want, we'll take it, where the breast conservation is done but patient did not receive radiation, was lost to follow up, came back with a no recurrence locally, mind you, but supraclavicle nodes. So
Definitely was done, and it was suggestive of ductal carcinoma.
So we were, she was not right in not receiving radiation, because that radiation portal would have covered supraclavicular port also, region also. So usually, conventionally, when we're giving radiation, it covers the chest wall, ipsilateral axilla, ipsilateral supraclavicular fossa, and internal memory. So generally, it would have got covered. So because she did not get radiation, she came back. So one is all breast conservation patient will receive radiation. So there is no confusion. So if you can't offer it, or it's not available, a patient not willing, or tumor different, don't offer breast conservation surgery. Second, all patients with a locally advanced breast carcinoma would receive radiation. You're right. All of them. There is no exception to the rule, so don't even try to think. So all LABCs, all breast conservations. 2, 3. You have done early breast cancer, but the nodes, what is the optimum number of nodes that you 10. Need to take out from the axilla? 10, yes. So if they are less than 10, suboptimal axillary dissection. Yes. We have no choice. You have to give radiation. Yes, sir. Or you do the dissection again. Yes. Yeah. So suboptimal axillary dissection, that's the third indication. Fourth, you've done optimal axillary dissection, but more than 4 nodes are positive. Then you have kind of the burden is heavy. So extra capsular spread, lymphovascular invasion, angiogenesis, and more than 4 nodes positive radiation. Then positive margins, always radiation. And rarely you can offer, if you are willing to include sarcomas. So all malignant phylloids that have recurring phylloids and malignant phylloids. Malignant phylloid, this is a debatable one. It depends on the grade, and some people say may not need it, but it is needed, and we have a case to share with you where in spite of radiation it came back. So yes. Mind you, radiation is not a completely morbidity-free modality. There are radiation-induced cancers too, which you should look at, and a lot of them are sarcomas. We discussed one today. So I'll tell you the answer again. Radiation in all patients undergoing breast conservation surgery, radiation in all patients of LABC, radiation in all patients with suboptimal axillary dissection, radiation, which means less than 10 nodes dissected in the axilla, yes. And more than 4 nodes out of 10 being positive, lymphovascular invasion, any tumor larger than 5 centimeters. So 3, 4, 5, grade 3, more than 4 nodes out of 10 positive, and more than 5 centimeters in size. Easy to remember. That can be done. Last question.
So it was about the breast conservation surgery.
Oh, the round block mastopexy video which you had posted on the YouTube. Well, she keeps posting them, but the discussion is you are supposed to get back with questions, and I'm glad there were questions. Look, round block mastopexy has been found to be a workhorse in my unit. This is the most common oncoplastic breast surgery that we do. We end up taking out tumors from all quadrants using the round block.
Yes.
You know that. And sometimes even beyond. It's a very useful technique. The best thing is you don't have a scar on the breast. And number two, a very interesting phenomenon I have observed. In fact, one of my postgraduates is doing a thesis this year on this being a workhorse, simply Benelli's technique. Benelli is the name of the technique. It's called round block because you take two round blocks, also called donut because it's like a donut that you have two concentric circles. So when you bring the purse string and neutralize the centrifugal force, the projection also improves. And cosmesis is very good, which you would see in that video. There are lots of pictures shown, and we do it all the time. So this is the most common oncoplastic surgery. Breast conservation surgery should only be offered in a center where it is possible. It should only be offered, it should be tailored to the patient. Early breast cancer, patient who is willing to follow up, patient who is willing for radiation and chemotherapy, and patient who is not pregnant and not in the phase. Pregnancy is not an absolute contraindication. I would put it down simply. If you're not good at the technique, because you should not make a hash of it, it should be oncologically safe, cosmetically good.
Right.
Otherwise, it should not be done. And then radiation is mandatory. So any situation which makes radiation difficult should not be a criteria should not be a case. So what should I say? We can do a lumpectomy and do a primary closure. There is no problem with that. It's only when the tissue loss is more than 30%, they say, of the breast, that you need to replace. Otherwise you can't. Otherwise you can do without. So you can do displacements, and replacements would mean a lot of tissue is lost. Oncoplastic breast surgery has a major advantage, especially in India. And it's an editorial of mine. If you're interested, you can read. It came out in IJ's last issue. Acting locally, thinking globally. It is like finding an Indian solution to Indian problems. Our tumors are large, so we can remove a bigger margin. We don't have, many centers don't have facility for frozen sections. So we can take out wider margins. If you know the art of oncoplasty, you can cover up larger defects with a good cosmetic outcome. So that makes it an even more of an Indian solution.
Yes.
So breast oncoplasty is level 1, level 2 and beyond. Level 1 is very easy. A lot of us do it all the time. Making the right incision at the right place. Like all of us should know, in the upper quadrants, incision is, you can take it along the nipple areolar complex axis. So it is circumferential. Inferior, we have radial incision, good. So even otherwise, when you're taking out a fibroadenoma, follow these principles of oncoplasty, you'll have a better outcome. So oncoplastic breast surgery is just to do the same job aesthetically.
Right. Without compromising the oncology.
Without compromising the oncological quality of it. You can take some cases now.
Yes. We'll now take the second case, which was provided in the group. A 14 years young child who came with a swelling of around 4 into 3 centimeters, which was present left to the midline in the upper neck region, and it was moving with deglutition, and it was also moving with protrusion of the tongue. CT scans were also provided, and so how would we approach this case, and what diagnosis would we make?
This was the case that we had in the OPD, you know that. This was a young 14-year girl with a classical video. That's why we shared with you. Look, these are patients that come in my OPD, and like I mentioned last time, they are all shared because they will be in the exam if they happen to be anywhere close. This is how the tongue protrusion test is done. A lot of people do it wrongly. What do? There is a swelling, as you mentioned, in the anterior neck.
Yes, sir.
And you can also say anterior triangle in the exam. It moves on deglutition and also on protrusion of tongue. You use this phrase in all thyroid swellings wrongly. It is not a, if you, I mean, I find it in exams wherever I go, it's a ritual to say thyroid swelling. There's a swelling in the middle of the neck which moves on deglutition and also moves on protrusion of tongue. You don't expect low-lying swellings which are large, and classically thyroid swellings, why should they move on protrusion of tongue? And then what do? I'll often ask them to demonstrate the tongue protrusion test, and they do it the wrong way. Remember, swellings that move on deglutition are not just thyroid, you know that. Pretracheal lymph nodes, subhyoid bursitis,
Yes, sir.
and of course thyroglossal cyst. These are options. Now remember, we did not do a few tests here, which is why this was left open. There was imaging the patient came with, so we will not share that imaging. There is no role of imaging here. We can do it, but it's not mandatory. So this image was shared just to let you know that it is an over-investigated patient as far as we are concerned. The diagnosis is clinical, and at best you can do ultrasound, which would be more useful than this image.
Right.
Now what else do we need to examine? I deliberately recorded this. I have done this examination, recorded this video to let you know that neck should be extended. Why? Because the thyroglossal tract is lying coiled. So you need to straighten it. Number two, if you have the neck flexed, you actually cannot see the swelling. And thirdly, you should see it from the lateral side. And it's an inspectory finding, not a palpatory finding. These are four things you need to observe.
Right.
In addition to this, I need to do palpation for fluctuation. I need to do translumination. Incidentally, it was transluminant and it was fluctuant too. And there were additional cervical lymph nodes. We did not send it to you, so it's not your fault. You can jump and make a diagnosis. With the tongue protrusion, what all swellings move. This swelling moves on deglutition, but also moves on protrusion of tongue. You're safe to call it a thyroglossal cyst. But what is the problem here? It's to the left of the midline. It's not in the midline. Maybe in that case there are two swellings. If you remember, we shared a ranula with you long back. I think last year, plunging ranula, last year. So I need to do bi-digital examination also. And interestingly, the swelling was, we were able to push it up and feel it in the floor of the mouth, which can happen with a large swelling anyway. You know, this would be called as a thyroglossal cyst as the first differential diagnosis. You'd also put subhyoid bursitis as a differential diagnosis. And can it be a lymph node? Well, unlikely, because why should the lymph node move? Yes, why should the lymph node move on protrusion of tongue? And it should not be transluminant, you're very right. So, investigations, how do you proceed? Now, don't just answer in the exam, I'll do cyst trunks operation and I'm happy. You would generally think, I've said cyst trunks operation, now the examiner should feel, oh my God, you're too good. You're too good anyway. But the point is, we need to investigate the patient for whether this is a cyst with the entire gland in it. One carcinoma that happens, which is related to thyroid, in a thyroglossal cyst is papillary carcinoma. So we need to do ultrasound to look for the remaining thyroid. If the thyroid is there in its normal position, then only I'll make a diagnosis. So my diagnosis would be based on triple test, which I do for thyroid anyway. History, clinical examination, ultrasound, and then maybe FNA. If this patient came with an FNA, I will confess, because you get lots of referred cases. So, and also the MRIs and CTs and what have you. She also has on ultrasound some nodes in the neck. So she has a relative who received anti-tubercular treatment some years ago. So there is a history of contact to the tubercular patient, but it should not deviate you, take you away from the diagnosis. Could it be a branchial cyst? Since it's lying in the anterior triangle, it is closer to the sternomastoid. You would say in your exam, I don't know, sir. My impression would be, based on my clinical examination shows it to be a transluminant swelling, which branchial cyst also can be, but it moves on protrusion of tongue. and distinctly moves on protrusion of tongue.
Right.
So I will use, like a Sherlock Holmes, I'll use clues of clinical examination to reach a diagnosis. So my clinical diagnosis would be thyroglossal cyst, and I would not like you to get confused by the imaging. If you look at the image, you are bound to get confused. That's why we shared the images with you. In the exam, even if somebody is trying to help you with images, some resident who is taken fancy for you, he tries to help you, don't take that help. The surest recipe to failure in the exam is to know the diagnosis. Approach it clinically. There is a swelling to the left of midline, close to midline. I have a problem there, but it moves on protrusion, on deglutition. So it is either related to which swelling move on deglutition. They have to have something to do with pretracheal fascia, its condensation, and the inferior constrictor. And so laryngo thyro complex.
Yes.
If that moves, it moves. So I am looking at, I can't be deviated from the basic physical clinical signs. That is the only idea of discussing this case. Diagnosis is written on the video. Transluminant, fluctuant, moves on deglutition, moves on protrusion of tongue. Tests done correctly. Why should I bother? I'll call it a thyroglossal cyst. And my approach would be ultrasound, neck, thyroid function tests, and triple test, which will mean ultrasound followed by FNA depending on my ultrasound findings. If there is no solid component in it, I may not do it. The treatment is surgery, and before surgery I'll take the consent from the counsel the patient's relatives, because she is a minor with the possibilities of surgery, the histology coming anyway. I have operated on a thyroglossal cyst that had a solid component, but it showed on ultrasound. So on ultrasound, if you suspect it, where would you take the FNAC from? From the solid component, not from the cystic part. So this ultrasound has been done. FNA would not be done just putting it into the cyst. No, ultrasound guided FNA. Therefore, triple test only. Clinical examination, ultrasound, and ultrasound guided FNA or a US FNA, which will be scraping of the wall or thickened part of the wall or the solid component, which may give me some surprise. Otherwise, the answer is surgery, which is cyst trunks operation. How do I do it? There's a video of mine, probably, can you upload it sometime? I'll just, it's a cyst trunks operation that I did in a young patient, where we make something like a collar incision high up, and we dissect the cyst from the hide bone. We go through because it is connected through the middle part, we spare the conua, and we go in the midline, follow the tract right up to the base of the tongue through the mylohide, and we request the anesthetist to push the tongue down so that you can get a bite from the base. We have a video. So we also take a chunk of the tissue of the tongue for histology, and we take the whole tract out and we just repair it. That's how it is done.
We'll now have the next case scenario. She's a 35 years lady who presented with a fungating and an also proliferative growth on the left cheek, which was also involving the lips, and the light could be seen through the lesion. The stage was T4B, N2B, M0, and the biopsy was done, which was suggestive of squamous cell carcinoma. She was referred to us from outside, and she had received neoadjuvant chemotherapy, which was cisplatin based. She had received all cycles, also with radiotherapy. The patient also has had trismus. I would like to ask, how would we approach this patient, and what would be the management in this case?
I think the patient was not referred from anywhere. The patient came with that stage to us, and we had discussed this patient in the tumor board, and it was decided, because this was a locally advanced carcinoma, squamous cell carcinoma. I remember this case in the tumor board, we had discussed it, and she received chemoradiation, cisplatinum based chemotherapy. She received all cycles and also radiation, and this is the present picture, which is showing hardly any improvement and no response. Now we are in a fix as to what should be done. Now the radiation is over, chemotherapy is over. Do we have a choice? But it is clinically not a resectable disease. So, our approach would be to first of all subject the patient to all the investigations to exclude any distant metastasis, which is unusual in head and neck cancer, squamous cell carcinoma. But if it has happened, then your answer is simple. You can't be aggressive locally and to lose distally. Suppose everything is fine distally, then we'll go for a very extensive surgery. Otherwise, this wound is going to be a hugely morbid affair. With radiation, the morbidity is extensive. During surgery also, we'll have difficulty with the flaps because the blood supply to the flaps is reduced tremendously and there is a possibility of flap failure. So these are patients who may not do very well in surgery, post-surgery also, but now there is no option but to salvage this patient. Therefore, it is called salvage surgery. Salvage surgery is a surgery done in a remnant or a recurrent disease. In this case, it's a remnant disease. We have not been able to treat her completely. And that would mean the left side commando, and the CT, the fresh CT would let us know as to what is the extent of the disease. Otherwise, we don't have an option. You can also counsel her, treat her with painkillers, palliative approach. I personally think this jiggery pokery doesn't really help the patient. We need to get this wound sorted, and there is my own publication on malignant wounds, which is pertaining to removing all the dead tissue, getting the cancer out is the best dressing that you can offer, and replace it with flaps. So we are planning in the tumor board, everybody has said there's nothing you can do beyond surgery. I mean, there's nothing else left. So we will resort to surgery. So what surgery will I do? Your answer in the exam would be, I'll counsel the patient that this is not a curative attempt. Should we do any surgery in head and neck which is not R0? The answer is no. But we'll explain to the patient that we will attempt, we may not succeed. Trismus means it's expected now because radiation would have caused it. The wound itself, the wound is extending beyond the retromolar trigon and it's going into the pterygoids, skull base, so it's an extensive work. So I'm not trying to teach you about doing surgery here. We have no choice. How do you manage the wound? So you should deal with such a case in the exam by saying, I'll manage the patient and manage the disease and the wound. Now, patient needs nutritional support, needs IV fluids, pain management, local care is very important. Oral mouth, the mouth care is very important. They stink and most people leave them alone. They are abandoned. So dressing with the wound is very important. Using substances like people use adsorbents, charcoal in the dressing, which adsorbs all the bad odor, or metrogel dressing, which we do routinely in these patients. Just soaking metrogel into the gauze piece and putting it is beneficial. Regular debrimer, and it's not going to bleed, getting the dead tissue out. Some people even offer maggot therapy, because if you don't, maggots find themselves. It's a very difficult scenario to manage them with palliative surgery. The surgery would mean you will have to resect it all around and get a clear margin. And that would be an extensive resection, if at all. Is there any role of palliative radiation later on? They've already given curative attempt with the complete radiation. The morbidity of radiation is also visible. You can see the changes in the skin. So limited options. Describe the case well. There is trismus. Trismus is not restriction of mouth opening. Trismus is painful restriction of mouth opening. So you need to take care of pain, local inflammation, painkillers, and salvage attempt. I think the second one, this one, you posted this case also?
Yes, sir.
Can you tell us about this case?
So he's a 45 years gentleman with history of chronic smoking and tobacco chewing, and presented with a similar ulceroproliferative growth present on the left cheek, which was around 5 into 6 centimeters, with everted margins, slough present on the floor, everted edges and slough present on the floor. And the patient also had a growth present in the left gingival sulcus, lower gingival sulcus. The growth was extending into the left retromolar trigon. There were cervical lymph nodes present. They were palpable at level 2B and 3 and level 4. And trismus was not present. There was adequate mouth opening, and examination of the cranial nerves 9th, 10th, 11th and 12th was normal.
We'll take it up. So I'll join the two cases. We'll take it up with the same approach. The diagnosis, first of all, this is carcinoma of the gingival sulcus involving the buccal mucosa also and extending beyond through the skin. So it's T4B, and the description is N1 M0. So patient would be put on how would I approach? Okay, that's what he said. Investigations to confirm the diagnosis, to support the diagnosis, to stage the disease and to treat the patient. To confirm the diagnosis, we'll take an edge biopsy, and as we discussed in previous cases, we need to provide antibiotic cover so that we don't get an equivocal diagnosis, and local mouth care to keep the mouth hygienically acceptable, non-infected, sending the biopsy, getting a contrast enhanced CT scan to stage it, which would mean that this contrast enhanced CT scan would be from skull base to clavicles to look for the levels of nodes. You said we think it is N1, but it may be more than that, and also the resectability of the disease. Now, putting the patient on neoadjuvant chemotherapy is the option that we have. It'll be a cisplatin based and no radiation, only chemotherapy, neoadjuvant chemotherapy followed by surgery, followed by adjuvant radiation is what I would plan in this case. For that, do I need a metastatic workup? Limited. But for lower disease, especially involving the level 3 and level 4 nodes, CT thorax is required because the disease being lower, and it's possible that there can be an extension of the disease. So we'll confirm the diagnosis by, I'm repeating, the edge biopsy after antibiotic cover and antisepsis of the whole cavity. We'll stage it by using a contrast enhanced CT scan, and metastatic workup is limited, and we'll treat this patient primarily, if possible, if it is resectable, which means if I'm capable of getting an R0 margin on CT, I'll assess it. I'll go in for upfront surgery because I think that is the best option. Of all the modalities, surgery is the least morbid. And naturally, radiation is out because the diseases involving the retromolar the gingival sulcus. So the mandible is likely to be involved. So in the presence of mandible involvement, radioosteonecrosis being a problem, I'll not subject this patient to radiation in the beginning. But after resection, I'll have to offer this patient adjuvant radiation. So neoadjuvant chemotherapy followed by surgery, which is wide local excision, which is basically would be a commando, and in this case, it will amount to removing the segment of mandible which is involved, along with the neck dissection, which is directly involved MRND type 1, and try to preserve interjugular vein. Contralateral nodes, if they are present, then contralateral neck dissection. So the management would be like any other oral malignancy of head and neck cancer as we manage.
Sir, I forgot to mention the patient also gave a history of loosening of teeth after he noticed this ulcerative lesion. So is there any significance of knowing the history?
Yes, the significance. If you find that the loosening happens later on, what would it indicate?
The involvement of the mandible.
Socket, the mandible. So this is a clinical feature or a clinical sign that the growth was not initially involving the mandible, but has now gone into the adjoining mandible. Involvement of the contiguous adjacent organ is T4 disease, no? And A, B is divided based on resectability. So when I said T4B, it was looking T4B, that's why I said it. But it will depend on whether, if T4B is when it's involving the skull base, around the carotids, it's a non-resectable disease, trismus. You said there's no trismus, but it will be restricted mouth opening. So if it is involving that, then it's T4B. If it is a resectable disease, but T4, because of the involvement of the contiguous adjoining organs, then we'll call it T4. So it'll mean that mandible is involved. Also, one more finding: if this is an extensive disease, sometimes you don't have the mandible involvement, teeth not getting loosened, but some nerve gets involved, which leads to hyposthesia in the chin. What is that?
Due to the involvement of inferior
Alveolar nerve. So that also is considered as involvement of mandible.
Right.
Because the alveolar nerve, inferior alveolar, has to go through the mandible. So there are lymphatics which go along the nerve. So hyposthesia of the chin, loosening of teeth after the growth, they both indicate involvement of mandible, and the planning can accordingly happen. Although you need a contrast and CT scan to know the extent. Now, some people also ask this question since you raised it: OPG versus contrast and CT scan in detecting the mandibular involvement. In detecting the mandibular involvement, both are equally good, equally sensitive. But CT can tell you more. So it tells you about the nodes, tells you about the extent of the disease, the retromolar trigon, skull base. So contrast enhanced CT scan is superior to OPG in the overall picture, but just the involvement of mandible you can find out by OPG. A good OPG is good enough.
So in this patient, how would you like to plan for reconstruction?
Reconstruction is a good question. The reconstruction depends on what I remove. So it is not going to be anything less than an axial flap. Free flap is an option. And like you know, I prefer local flaps because they cause less morbidity.
Yes.
So I'm expecting to remove what all here? The skin, the muscle, the bone. So I'll need an osteomyocutaneous flap, or at least a myocutaneous flap if I don't want to replace the bone, because mandible, posterior segment, and if you disconnect it, can lead to many problems, including endergomp and many other deformities. Endergomp is of course the anterior segment. So I would be planning an osteomyocutaneous flap. The one that I commonly use, which is quickly done, not involving a long microvascular surgery, is
Superficially, the PMMC flap.
PMMC flap with the deltopectoral flap, which can both come up easily. I can take a PMMC along with the rib. So that will become an osteomyocutaneous flap. That will go for the inner lining, and I can put the deltopectoral flap, which is based on. Now, what is PMMC flap based on?
Pectoral branch of thoracic.
Good. So I can use that flap because it is based on a known pedicle. And what is an axial flap?
Which has a known blood supply and
Not a random flap, a known blood supply, named blood supply. So both have named ones. Deltopectoral flaps are based on?
the perforating branches from internal marrow.
Yes, that's good. So both, so PMMC can go inside, the skin inside,
Yes.
and DP can come on top. And you can have the rib in between to take care. So that is how I'm going to reconstruct.
Thank you, sir. We'll now take up the ward round scenarios, and the first one.
Accessory muscles or respiration coming handy. See that? Breathing noisy. Hard. What is happening? Rider, and you can see she's breathless. Face is engorged. Let's not trouble her more. Classical positive. These are the carotid pulsations. Pratik, go and take the call. This is stenomastoid. The carotid pulsations are displaced. This is the pulsation. Now I am feeling it. Okay. Similarly, the pulsation on the other side. Now to the chest veins. Dilated chest veins, which would suggest a retrosternal extension. खूब सटकिए माता जी, खूब घुटिए. Slight movement, बस. Carotid pulsation here also. Please cover that patient. See the pulsations and the neck veins. Classically involved.
A 68 years lady who presented to us with a swelling in the neck which was present since 20 years. She came to us with sudden onset difficulty in breathing, sudden increase in the size of the swelling with change in the voice for past 6 months. She on examination had stridor. There was a huge thyroid swelling which was around 20 into 15 centimeters with nodular surface, hard consistency. The lower border could not be reached and there were multiple dilated veins on the chest, and on palpation the carotids were displaced posteriorly. Now we had provided this case in the group and there was a discussion following that. The audio was also provided to that effect. She underwent surgery. The report came out to be of anaplastic carcinoma. I would like to read the report also, the histopathology report. It showed a total thyroidectomy specimen which was measured to be 14 into 11 into 2.5 centimeter, and the right lobe measured 11 into 7 into 1.5 and the left lobe measured 4 into 2.5 into 1 centimeter. The posterior surface of the left lobe, right lobe anastomus showed breach of capsule with ragged irregular surface. And on cut section, the grey-white friable tumor was identified in both the lobes and isthmus, which measured 10 into 7 into 1.5 centimeters. It was replacing the normal thyroid in both the lobes and isthmus. Multiple sections which were submitted showed near total replacement of the thyroid parenchyma by a tumor occupying both the lobes and isthmus, and was reaching up to the external surface. The tumor was composed of viable and necrotic areas. The individual tumor cells were polygonal, focally spindle shaped. They had highly pleomorphic vesicular nuclei. Most of the areas showed squamoid differentiation with keratin pearl formation, and the other areas showed sarcomatous differentiation with high-grade pleomorphic nuclei and multinucleated giant cells. The remaining residual thyroid parenchyma was unremarkable. Retrosternal extension from thyroid and right lobe also showed tumor having similar features. The lymph nodes at level 3, lymph nodes were involved and showed metastatic tumor deposits, and the impression was made of an anaplastic carcinoma of the thyroid with metastatic tumor deposits at level 3 lymph node. I would like to ask sir that how would one arrive at the diagnosis of anaplastic carcinoma?
Well, this was a case that was posted in the group, I think last month or maybe this month. We are in June, so last month. And a lot of you answered very well. I'll remember some people. Dinesh answered very well. Murtaza answered very well. Murtaza has passed his exam and is gone. They've done well, all of them. Aditya answered. A lot of people answered very well. In fact, this was a very well discussed case. We got maximum replies because it was a video that I had posted, and I had recorded this video in an OPD setting. Arush will recall. It was a classical stridor. There was engorged veins on the chest wall. There was no question of doing Pemberton. She would have died. She came as an emergency. She was brought on a wheelchair because she could not be put supine. She was not able to breathe. And the carotids were pushed away, pushed backwards. Trachea obviously couldn't be palpated. And she was in clear respiratory distress, needing an emergency intervention. So basically, we had planned an emergency intervention just to bear the trachea, because the clinical diagnosis was anaplastic carcinoma. It was a hard gland involving all the aspects of the neck. There is nothing else that could be felt. Naturally, with the sternomastoid being pushed away, carotids having been pushed away, so it was occupying all of it. Thyroid fossa had got extended. The boundaries of thyroid fossa are medial border of sternomastoids, hyoid and suprasternal notch. And there was definite retrosternal extension, which was what was leading to superior vena cava syndrome. And you could see all the dilated chest veins. I'm sure Sukriti would share with you I made it a point to put the day 1 video, day 2 video, day 3 video to know the changes that happen. Well, the question is, how do you make a diagnosis? Anaplastic carcinoma is a clinical diagnosis, like we talked about the inflammatory breast cancer. This patient was elderly, so that's one criteria. She had a goiter for more than 35 years. which had suddenly grown last 6 months, leading to tachypnea, stridor. She had orthopnea, she had stridor, and it was recorded and you heard it all. Clear stridor. There was superior vena cava syndrome there, so there was it extended all over. So, and on examination, this is the clinical history. On examination, this change itself would indicate there is an anaplastic change in a goiter. You can't just say malignant change, because malignant change would be gradual. Number 2, she had nodes, which are also hard, but they were palpated along the gland, they couldn't be separately palpated. In addition, she had the imaging and the other features also pointing towards the tumor being malignant. The CT scan, which was patient brought with her. I don't do CT scan in these patients because of the iodine related issues, but it showed heterogeneous appearance. It was all tumor. So the diagnosis of anaplastic carcinoma is then on examination hard variegated consistency, which means all 3 components: hard, firm and soft. So evolving cancer, dissolving cancer, both present. Next, ideally you should do a core needle biopsy. This is the only time, and probably two situations where core needle biopsy in thyroid is very useful. One is anaplastic carcinoma, the other is lymphoma. Because if you can make a diagnosis of lymphoma, that can be treated without surgery. You can treat the patient with radiation or chemotherapy. So these are the only 2 indications for core biopsy. So they recommend core biopsy because then anaplastic can be made. We could not do a core biopsy. She came with an FNAC. Patient was in distress. We had to take her up as an emergency. So we took her up as a semi-emergency, and very high risk consent was taken. The anesthetist was taken into confidence, and you need a very good anesthesia for such patients. So naturally, they did fiber optic, and the surgery involved. That was the part 2 you asked, no?
Yes.
Now, how would be the pre-operative, per-operative? Okay, the operative and post-operative findings. Okay. So I went with the collar incision, which you will see in the video and the picture. I hope the operative videos are also there. Some of the operative videos are there, so you can share. You can provide them so that they will know. Now, I made a utility incision rather than just a collar, which means the collar incision extended upwards towards this to the mastoid process is called utility incision, because I had to do, if at all possible, neck dissection, because I didn't know what I'll be able to do. And CT had confirmed it to be grade 3, scoring 3 retrosternal extension. So it was a big extension which was hanging onto subclavian vein. So that would mean I was ready for sternotomy. So that's the next preparation you need to do. So we had kept the sternotomy set ready, which can be done easily. You just have to split it open and you can remove the nodes and the tumor under vision. Now, preparation for sternotomy, possibly a thoracotomy, because you need to have a control on these vessels. Otherwise, the plan was to just bare the trachea and secure the airway. This could be your answer in the exam. Sir, I will just get a core biopsy to get a diagnosis. Once I've got a diagnosis, I'll just make sure that the airway is not affected. What's the best way to manage airway? Not tracheostomy. Why? Because tracheostomy would open up a channel for the growth to go into the trachea, and that will actually kill off all the issues. You will have nothing to do. Endotracheal intubation is much better in this situation. This is one situation where you have no choice. So after the intubation, everything, we took up the patient for surgery, and I did a lateral to medial approach, starting on the right side, where I started from the carotids. So as is my approach, I started with getting hold of the pedicles. So with the carotid getting retracted, I'm sure this video would be interesting for you to watch. We cleared off the entire gland from its attachment to the prevertebral fascia, lifted up. Along with that came all the levels, because you don't need to really go looking. They will come along. And superior thyroid artery was going upwards rather than downwards, because the gland had taken it up. So we cleared it off, and in one clip you would see that we had to separate it from the submandibular gland, which was not looking separable because it had gone beyond digastric actually. So we took out a portion of the submandibular gland. In fact, the superficial lobe, all of it would have been taken off. So I decided to go lateral to medial, aggressive approach, and we cleared it down to, but we demonstrated the external laryngeal nerve using the same Nihas maneuver, pulling the lobe down and out, and we saw the nerve going in, and we traced it, ligated the pedicle and came down. And after doing the right side, we had a grip on the gland, but did not pull out the retrosternal part even now. On the right side was a little bit only, left side was more into the retrosternal space. So usually that is what happens. Easier access from the left side, so it tends to go that way. So then we did the left side, similar approach. On the left side we had very clear nodes which come out to be positive, they looked positive also.
Yes.
And we did the level 2, 3, 4 dissection. Level 1 happened because the gland was infiltrating into the submandibular gland. I mean, it's gone that big, node was there. So level 1, 2, 3, 4, not 5. 5 happened on the left side because we could see that we had the sternomastoid lifted up and we could go under the surface and we could clear out the nodes. But again, external laryngeal nerve, recurrent laryngeal nerve on both sides were seen and preserved. We could only find out 2 parathyroids, and we actually did not know what to do with the third one, which again we put it down somewhere as an auto transplant video. We did put back one, but we were not sure whether they'll take up. Is it required or recommended or not? I looked at the gland and then I removed that also because I thought I should not leave behind a lymph node with a disease because that I could not make a diagnosis of it. So so surgery was taxing, but it's rewarding. I was initially not sure I'll be able to handle the trachea there. Then we reached the trachea and the anesthetist was worried about the trachea because they tend to have a very weak trachea which tends to have tracheomalacia. So we found that it was not a very strong trachea. So as a protective measure, I had removed the strap muscles, so there were no strap muscles left. So only the sternomastoids were left. We had to remove the strap muscles along with the tumor because they would not otherwise come out R0. In spite of that, posteriorly there was one place where the capsule is breached. It doesn't matter in thyroid because it's an anaplastic growth. We have to get as much. This is also a situation where external beam radiotherapy would help because it's anaplastic. And if you read the pathology report, that's why I asked you to read it. There is a squamous element. We don't know. I have published 2 cases of primary squamous cell carcinoma of thyroid way back, an aggressive tumor which behaves like behaves like anaplastic carcinoma of thyroid only. So we did that, and post-operatively it's important to look for. I mean, so what did I do for the trachea which was weak? I requested the anesthetist didn't want to extubate, which is right. But as a protective measure, I had hitched the trachea using the hitching sutures to the sternomastoid. So it's kind of, this is what is done if you're suspecting tracheomalacia in the post-operative period, that you hitch it to strap muscles. But we didn't have strap muscles here. We hitch it to strap muscles so that it doesn't collapse. The strap muscles keep holding it, right? Sometimes you can do a tracheostomy. That was a point we were, but I didn't want to do a tracheostomy because if I had left behind a disease, the disease would get into the trachea and would have harmed the patient more than benefiting. And therefore, intubation and hitching it to the sternomastoids is all that we did. Post-operatively, the serum calcium was 6.5 or something, and I was not surprised. Patient was also hypoalbuminic, which can give you a false low levels. Patient was on calcium supplement, so we did send for parathormone levels, which we do as a routine, as a project. So we did that, and serum parathormone was sent. It was striking range. It was not completely knocked off. So we are hoping, but most important sign of the fact that we have not caused hypoparathyroidism is to see the parathyroids on the table, which I've discussed in many thyroid cases. We saw 2 of them for sure, so I was sure that will work. So initially it's a stunning effect which bothers you for a while, it settles. So she settled. Her voice was perfect. We recorded the video on day 1. In fact, she was able to speak even better now, and in fact I was arguing that your nerves were all compressed by the tumor, your voice has got better.
And engorged vessels were also...
Yes, and you saw the veins completely emptied, so the results were remarkable. The distress was gone. but we kept the nasogastric tube for feeding for some time, because initially I was not happy with the external laryngeal nerve of the left side. So that can cause the aspiration in these patients. They can cough, but gradually it settled. Now she came yesterday, and that picture also we posted. So we're getting the tube out, and Ralph's tube, nasogastric tube out, and she'll be allowed oral feed. The shield after this, the report is very clear. It's anaplastic carcinoma, where rarely you may get away by doing surgery, but less than adequate surgery can be dangerous. But the result shows that it is possible to do if you do it regularly, demanding surgery. But we could now offer her adjuvant radiation and be done with it.
So did you require to do sternotomy for?
No, we did not. Yes, the retrosternal extension. Yes, that part I forgot. I'm sorry. Now, once we've got the superior pedicles sorted, we manage it. Even in the past, when we talked about retrosternal extension, there is no rocket science here. Most retrosternal goiters are taken up through the cervical route only. But we were ready for any disaster, because it was stuck to subclavian. There was one feeding vein which was direct. I could ligate it, and then you would see in the video we could use the dissection of the mixture, right angle mixture completely, and we could actually deliver it. So what I do is superior pole ligate it, the middle thyroid vein, and everything is, now the gland is in your control. It is possible to apply traction and retract and go gently. This is one place where you have to be patient. And like if you go through my article on 10 commandments of safe and optimum thyroid surgery, the first one is the most important. Surgeons operating by clock have no business to be here, but this is going to cause disaster otherwise. So we didn't require a sternotomy, and in so many years I've required it in only 2 cases, papillary, where the nodes are extending, so I had no choice. But it is possible to avoid it. In this case we could manage.
So how would we follow up these patients in a
Like I said, we have the histopathology report, and would we do a scan? Well, to me it doesn't matter anymore. Now we have done what we could, and now the patient should get EBRT, that is external beam radiation, and we'll discuss it in the tumor board. Scan won't take up, because anaplastic carcinomas don't take up radioactive iodine. So it is not a case where you would manage by radioactive iodine. So we will keep in follow up. Scan has an advantage, it can pick up metastasis elsewhere, but not in this case. We'll manage it by external beam radiation, and that should do. There is also a doxorubicin based chemotherapy which is given to these patients. So there is a role of chemotherapy, there is a role of radiation in these patients. So that's what we will do.
Thank you, sir. We'll now take up the last ward case scenario for today. And this was a 65 years gentleman who presented to the surgical emergency with features of acute intestinal obstruction. We suspected it to be a large bowel obstruction. The patient was optimized and was taken up for surgery. Intraoperatively, there was a growth which was identified at the rectosigmoid junction with multiple mesenteric lymph nodes that were enlarged. In this case, Hartmann's procedure was done, and I would like to ask a few questions to sir pertaining to this case. The first question is, how do we decide for whether definitive resection could be done in this patient in a emergency scenario or not?
Well, a classical malignant obstruction. The growth was at the rectosigmoid junction. I know this case was operated day before yesterday. The growth was completely occluding. Left-sided growths are completely, they're stenosing growths, right? Right-sided ones are ulceroproliferative, they bleed. Left side they produce spurious diarrhea, and it takes about, how long does it take for the whole circumference to be involved?
1/4 gets involved in 6 months, so 2 years for the complete
Good, good. So it's definitely 2 years old, in fact more. Elderly person, two years old growth, I'll be surprised if there are no metastasis in the lymph nodes, and if the liver was normal, yes, the liver was perhaps normal on examination during surgery. Now your question was decision about definitive surgery. Okay. See, you should learn in surgery to survive, live to fight another day. Do not do a definitive surgery that kills the patient. I mean, a very good surgery with 100% mortality is a bad surgery. So firstly, defensively, you should be defensive. This is not an early case. This is not somebody who is going to be fit for surgery. He has come for obstruction. It's an emergency. And the performance status of the patient is not at its best. The performance status of the operating surgeon is also not at its best. The performance status of the operation theatre is also not at its best. The performance status of the bowel is not at its best. So there's nothing at its best. So why should we try the most definitive treatment? It is likely to fail. You may succeed once in a while, but that's not called success. You should be able to succeed with that attempt each time. So the answer is we will not do emergency surgery, which is definitive, because the patient is not. I have given an answer to that.
Yes.
Now, therefore, what do we do? When do we do definitive surgery? When the patient comes in obstruction, it's not justifiable. You should not. And that's how Hartmann's procedure came into existence, where you resect the tumor, but with a clear margin. It's not that you do a airy-fairy surgery, some kind of a toilet colectomy, whatever name you want to give that fancy name. It's clear resection with a clear margin. It's a proper surgery, but no anastomosis is done. That's what I'm trying to say. So it's no less surgery. The resection is with adequate margin of about 8 to 10 centimeters and distally 5 centimeters, because distally we need less margin. You know that the lymphatic drainage is upwards in the sigmoid and rectum. That's why we are able to do sphincter sparing surgery in the anorectal cancers, because we can do with a centimeter beyond, that's it. But proximally we need margin, and it's possible to do that. So therefore resection, but if you anastomose, that's when that factor comes into play. Suppose this patient was a very fit patient, worked up, bowel, everything is fine, you can go in for that. So does that answer the question?
Yes.
Part 2 you asked me was, is the bowel preparation possible on the table?
Yes.
That's a brilliant question, I must tell you. Reason? Because it was a practice. When we were training, it was a routine. What do you do there? You'll do various methods. And there are papers published left, right and center on the table bowel preparation, and then you can do anastomosis. If you're going to do Hartmann's anyway, there's no question of preparing the bowel. So I'm sure you're asking with anastomosis in mind, which I've already told you will never do. So bowel preparation is actually functionally out. Now why it is out is all what I'm going to tell you. So they would do appendicectomy, use that stoma to do pushing saline, clearing it off here, pushing saline, clearing it off here, pushing saline. It was murky, dirty, filthy, and it added to infection. In the best of centers, it did not help in improving the outcome. Today, even in a normal setting, when the patient is going for a definitive surgery also, there is no advantage shown with bowel preparation. So gone are the days of putting the patient fasting and on pig leg for days together, enema from below, cathartics from above, making the hell out of the patient. Is no longer done because they didn't find any improvement. In fact, there are studies to show it can add to infections. If you are operating on this patient, something else would be important: antibiotic prophylaxis, taking all the aseptic precautions, not touching the tumor, coming out clean, getting the stoma, getting the hell out of there. So there is no question of doing definitive surgery, and therefore also no bowel preparation.
The next question that I would like to ask, that the Hartmann's procedure was done in this case, And also intraoperatively, multiple mesenteric nodes were also found to be enlarged. So would we clear the nodes in this patient?
And that's a very good question, actually. That's what training is all about. If you just chop it off like a sausage, it's bad surgery. So when you're doing colectomy of any kind, this will be segmental colectomy.
Yes, sir.
You should go to the base of the pedicle. And when you ligate the pedicle, you'll get the nodes. If you just go along the bowel, you'll miss the nodes. Does it help? Does it change the outcome? The question is, I can't quote a situation where bad surgery can help. Optimum surgery is the bare minimum that you need to do, and that is going down to the pedicle. And you'll have rectosigmoid growth would be what? They'll be coming from inferior mesenteric. You can trace them, sigmoidal, left colic sigmoidal branches. So when you're going for those vessels, the pedicle, the nodes will come. So we get the lymphovascular bundles out. And that is why even in this resection, segmental resection, my registrar would do the clearance from the pedicle where it is attached. So automatically the lymphatics and the lymph nodes, along with, it will be an arm block resection. All that they are not doing is anastomosis. Rest should be, they should be trained into doing a proper surgery, which means removing it along with its pedicles, therefore the lymphatics, lymphovascular pedicle I'm saying, which means the lymph nodes also.
Right. So is there any role of perioperative endoscopy in this patient?
Well, in a cold scenario, yes, you can push in a scope through the colon and see if there are any synchronous lesions. Here it won't matter because this is the one lesion which needs surgery for obstruction, and we need to go for this, right? So there is no role, but in a cold scenario, there is a role to find out any synchronous lesions or polyps which may be addressed in the same go.
Yes. As you mentioned that if the liver Hartmann's procedure in this case, but in case intraoperatively, if there was metastasis to the liver also, how would the management change?
One thing, we will not do metastatectomy in emergency setting because of the same reason. But in a planned setting, it gives you an opportunity to observe. You know, what will you do? Hartmann's you've done. Now the question is, how do you follow up these patients? We'll have a CEA done. We'll have the CT scan done again. We'll see the liver markers. We'll look for everything. And liver will have metastasis. So we have then an option to treat with chemotherapy. So when you put these patients on chemotherapy, systemic therapy, FOLFOX or FOLFIRI, because there's no point in anastomosing now, we'll put the patient on therapy now. Right. And it will be a locally advanced disease, as I can see. So the liver metastasis would also be responding, if at all. If they don't respond, so when we go in for definitive surgery, we can do metastatectomy. You know that metastasis to the liver is not taken as an M1 disease. We take it as we resect it, provided it's one metastasis, solitary metastasis, or a lot of them in one segment or maybe in one lobe. It can be done. Anatomical resection is not done, but we get a clear margin. And there is a role then, chemoembolization, doing hepatic artery embolization to make it smaller. Operating in an emergency scenario would be unfair. That will not be, it will amount to the same thing. Right. A living problem is better than a dead solution. So we should not do what is not required here. I hope that takes care of it.
Yes, sir. So, anything special in the post-operative management of this case?
Like I said, we'll follow it up with, we'll have a baseline markers, CT scan. This patient would definitely be discussed in the tumor board. Histology would be important. Whether it is that. No, it is an adeno. It is adeno. We have that evidence, but which type? Mucinous, non-mucinous. The one with pseudomucin the signet ring type, which has a very bad prognosis. And then we'll get a KRAS mutation gene to plan on the chemotherapy, and everything would depend. Basically, this patient would need a follow-up chemotherapy, and then closure would be after we have dealt with everything. including metastasis to the liver, which can be dealt with chemoembolization, with yes, a metastatectomy in the same setting can then be done. There is a controversy about, some people like to do the metastasis first, then the primary. But here we have resected the primary because it was obstructing. The indications for surgery in emergency for malignancies are usually obstruction and perforation. I am talking about the gut malignancies.
Right. Thank you so much, sir.
I'm sure it was an exhaustive one. She had framed up too many questions, and we'll be happy to get your feedback, because that is what will make it relevant. I mean, if you're finding it useful, we ought to know, because that feedback is what decides how do we do it next time, what is it that we do. If there's still some questions, some people have posted, we've included those questions, and we provided you the scenario a little, we gave you a shorter time duration. We can do that longer, but we wanted to do it on a Sunday when you can comfortably watch. So thank you, Sukriti, for arranging all this for all the postgraduates, because it needs a lot of doing. You're putting things together, getting all the cases together, and your feedback is therefore very, very important. Thank you all very much. Thank you.
So this was the last ward case scenario, and I'm sure you all are going to find it very useful for your exams, and as well as for the daily ward management of the patients. And I would like to thank Sir for his time and dedication for bringing all these cases and very valuable discussions for all of us. Thank you so much, sir.
It's a pleasure, Sukriti, and I must thank her for arranging all these cases for all of you, and I would request you all to give a feedback on the way we organize it. These are all put together with a lot of effort, and we do keep giving you those case scenarios, but we need to know regarding the how do you find it and what more can be done. Scope dates, there's some other activity coinciding with it, which is probably RRC happening in Jaipur. Some students were writing, so we are trying to arrange maybe in the week after that, because you can't delay it any further, because it's very important for those who go in for exams around November, December, and we need to book in early, because the auditorium that we have this time is not as big as the one we had last time, and the capacity being limited to 250 plus. So please register early, otherwise don't blame us, because last time we had 378 people, and then there were about another 20 that I had to adjust. So they sat around, but I would love to see you all coming. So do register in early. Now the details about which bank, wherever, etc., they would be sent from the chapter. It will soon reach you. But meanwhile, you can write to us in the group regarding your name and institution.
And the email addresses so that we can contact you.
Yes, email address, so that you can be sent a confirmation. For us, that is a registration as far as we are concerned. And do send in cases that you would like to present. Would you like to tell more about that?
Yes, all those who are interested in presenting a case during the scope, they are requested to send their title of the case along with their names and other details to our to the email address, that is scope.surgery@gmail.com, and we'll send a confirmation mail after reviewing all the presentations that we receive.
Thank you
Very much.
Thank you
So much, sir.